welcome to Health Issues. I'm your host, Chris Sylvain, and we're thoroughly excited about today's show, and we get a chance to tackle probably one of the most interesting issues that we've seen in medicine today. And we have an awesome guest, and it's kind of a rarity. There's not that many around, but we have a pediatric endocrinologist on the show today, Dr. Stuart Chalew. I have it right? I'm good?
Yes, thank you.
All right. Pleasure having you. And just recently there was a study, and you were able to comment on it. And tell us a little bit about this study.
Okay, well, there had been smaller studies, and actually we did one back in the 2000, where we had looked at our patients with juvenile diabetes, or it's called now type 1 diabetes. So these are all kids with diabetes that requires insulin for its survival. And we were interested in the outcomes of our patients. And one of the factors that we looked at was ethnicity. And it turned out at the time the main measure of how patients are doing is something called hemoglobin A1c, which is thought to measure what your average glucose is during the last 3 months. Mm-hmm. And it turns out that we found that our patients, African American patients, tended to have higher A1Cs than the white patients. And roll that a little bit forward, a couple of years back, we looked again at this data, and we confirmed that, here again, the African American patients tended to have higher A1Cs, not only statistically significant, but clinically significant difference. And the little nuance in this study was not only did we look at the A1C, but we also had a lot of glucose data from the meters that they take home with them and measure their glucoses. And we were able to calculate what their actual glucose was and compare it to what the A1C was. It turns out that if you adjust and look at the A1C with regard to what the glucose is, it turns out that in our African American patients, hemoglobin A1C kind of overestimates what your real glucose is. Really? For some reason. And here this was a small study in about 150 patients at Children's, but subsequent to that, there have been other studies that have looked in patients with type 2 diabetes, have looked at larger populations of people without diabetes, and it turns out that in general, African Americans, or actually individuals of African heritage, because some of these studies have been done in Europe, where they have people who have emigrated from Africa. So people of African heritage tend to have higher hemoglobin A1C than people of European heritage, even at the same blood glucose. So this means that many African Americans have hemoglobin A1Cs that tend to overestimate what their mean blood glucose is. So that was one of the findings of our study. Our studies have been relatively small. We have a limited number of patients at Children's Hospital, but the article that you were referring to was a consortium, a group of diabetes centers across the country. It's about 60 centers, and they looked at their patient experience in about 10,000 children with type 1 diabetes across the country. And about a year ago, they just looked in general about how well kids were doing with their hemoglobin A1C. And they found a very disturbing fact was that most kids with type 1 diabetes are not getting treated to what the optimal goal for the hemoglobin A1C was. So there's a lot of discomfort about why are we not able to get patients better controlled. And this has a lot of implications, because the higher your hemoglobin A1C is, the higher your glucose, the more likely you are to get bad complications as you get older. And just to remind you, the complications we're worried about are, eye damage, retinal damage, could cause blindness, kidney damage, and go into renal failure and need a kidney transplant, nerve damage. You're more prone to cardiovascular disease. So many patients with diabetes who don't take care of themselves die prematurely and certainly have very serious complications and decreased quality of life. So our treatment goals are to get the numbers, the glucose numbers, as close to normal as we can, because that's been shown to help prevent complications. So it was disturbing that one of the main indicators we use, the hemoglobin A1c, in majority of kids is just not close to where most experts would like it to be. So that was the study about a year ago. So this group comes back now this year and have sort of cored into what's going on, and coming up with more disturbing information. And one of the disturbing information was, they looked at the ethnicity of the patients, and here again they replicated the findings from our previous studies, and other people have shown in smaller studies that African Americans tend to have higher hemoglobin A1Cs than white patients. But now this is a very solidly large number of patients. You could say, well, maybe in New Orleans something's different, or maybe in Boston or Florida, wherever you're looking. This was a real scattered across the country, a large number of patients, and still the African Americans were consistently higher. And this is now, 15 years after our original study. There's been a lot of changes. We have these wonderful advances in technology. We have great pumps. We have great meters. We have continuous glucose monitoring. We have fancy designer insulins, all these things which were designed to help patients get better outcomes. And with all these bells and whistles we have, we're still not succeeding in a lot of kids, and there's still this ethnic divide, this gap in outcome. What the study didn't do was to look at, here again, some measure of the glucose in comparison with the A1C. We were talking before that we feel that the A1C in African Americans tends to overestimate what their mean blood glucose is. But there was another interesting finding in that, and I think most doctors would like to get their patients to a goal, and if they're very often hemoglobin A1Cs are readily available. And I think when many doctors see a hemoglobin A1C that's high, they'll try to ratchet up the insulin a little bit. And let's say the A1Cs really overestimated your glucose. Well, if that would be so, and you're not really paying attention closely to the glucose, as you say, well, the A1C must be the same as the mean blood glucose, and you give more insulin, I think it's more likely that those kids are going to have hypoglycemia. So guess what? The curious finding in this study was that the African American patients reported more hypoglycemia, even though they had higher A1C. So it's sort of a disturbing and unclear reason why that might be, unless perhaps the A1C in African Americans overestimates what their blood glucose is. So that's actually an area of research that we're involved in to see, is this really so? There are many more sophisticated ways of looking at this than we did, even 5-10 years ago. So there are ways to look into that. The other would be, if that's true, what are the factors that might lead to our patients being at higher risk, having higher A1Cs that they should? Does that, now you say, well, if their glucoses aren't really different, but their A1Cs are higher, does that really translate into more complications? We worry about that because you're probably aware mortality in African Americans with diabetes tends to be higher. Complications tend to, renal failure, kidney disease tends to be higher. So it may be, even though the glucoses aren't higher, there may be an extra factor which predisposes African Americans to complications that we may just not be able to fix with insulin. And maybe we need a new medication that might close this gap, this difference in hemoglobin glycation and glycation of other factors in our patients.
Yeah, well, I guess we saw that with high blood pressure, that another drug was able to be more targeted for African Americans. Very, very controversial. But from a geneticist standpoint, the genetic implications of it.
I think that's something we haven't only beginning to tap into. We haven't tapped into that. We're proposing to look at that a little closer. There has been one report looking at individuals without diabetes. Now that they have all these fancy genetic genome surveys.
Right.
Many of these surveys have been done in patients of European or Asian origin. There have been very few on individuals of African heritage. But there has been one done looking at hemoglobin A1c. And there does seem, the first study came out of a European population, and they were able to identify about 11 locations in our genome where genes might directly affect the hemoglobin A1c. There was a study that looked at, like I said, non-diabetic individuals, and then they were able to look at a population of African heritage individuals versus European heritage individuals. And the African heritage individuals tended to have differences at 5 of these what they call loci. These are spots in the genome which were thought to affect hemoglobin A1c. So there may be a very like you say, a basic genomic difference. If we could now have to core into that, find out exactly what it is, maybe there would be a way to modify this difference. If we knew what the gene was, or what the gene product was, or what seemed to cause the higher A1Cs, it might open up a new method of treatment for people. So I think your question's very important. We just have to keep tracking that down and see, because it could open up a whole new treatment for prevention of complications.
Fantastic. Yeah. Well, but it seems as though, almost a slam dunk, because the differences between African Americans and people of African heritage and whites, as far as for the relationship between A1C and glucose levels. So that's we know that, though. We're comfortable with that. It's just it hadn't been proven yet that it's purely genetic, but.
Well, it's going to be one of the factors. Unfortunately, many of our patients, besides maybe genetic tendencies to complications, which maybe new drugs would help us prevent, many of our patients, my patients here in New Orleans, tend to be underserved. They tend to be indigent. They tend to be in households where there's a low educational background, and I think this makes it harder for people when they're struggling to keep a roof over their heads or get meals than to have a very complicated treatment. Being a diabetic isn't easy. It's very difficult. I refer to it as being particularly the most common form of diabetes that my patients have, where they need insulin throughout the day for their very survival. I refer to it as 24/7, 365. I mean, they never get to forget that they have this type of diabetes, and if they forget, it bites them back. They get very sick very quickly.
I guess the interesting thing is, even if it's genetic or not, there are lifestyle things that can affect even type 1 or type 2 diabetics.
Absolutely.
So
the way you eat, what you eat, just simply remembering to take your insulin before you eat. You would think that would be a simple thing, but kids tend to be kids, and they don't always sit down to have 3 meals of the right consistency and take their insulin appropriately beforehand. So hopefully that's part of what they'll learn to do in their training. Maybe part of what needs to be done to help them improve above and beyond the genetic factors.
Interesting. It really, really is. But this whole idea, pediatric endocrinology, again, that's one, it's a lot different than what it was 20 years ago or even 10 years ago, the whole concept of pediatric endocrinology, because of kids now weigh more. They, as far as for type 2 diabetes, and now you have, 15 and 16-year-olds with type 2 diabetes?
We've had some 8-year-olds with type 2 diabetes. What's interesting now, this really is there are probably strong ethnic differences, because in New Orleans, type 2 diabetes is almost completely an affliction of African American patients. If you'd go to San Antonio, probably you'd find mostly Mexican American patients. If you went to Phoenix, it would probably be Native Americans. Very strongly genetic effect on this, we don't know exactly what it is that predisposes a lot of individuals. But if you would say, what's the typical patient in our clinic of type 2, they're African American. It's not unusual for the one or other of the parents to have had diabetes, obesity-related diabetes, or certainly grandparents with obesity-related diabetes. These kids are typically not just a little overweight, but considerably overweight. Tends to be twice as many girls as boys. Really? And the average age of our patients is about 13. But we've, like I was saying, we've had kids as young as 7 and 8. 7
and 8. Now, type 1 is still pretty rare in and of itself, with numbers-wise compared to type 2.
The most popular form in our clinic is still type 1.
Okay.
But I would say of our African American adolescents, about 50% of our kids, adolescent kids, have type 2. We still get about 2 new type 1 patients a week, and about 2 new type 2 patients a month. So we
pediatric endocrinology. We're not talking
18,
about
kids
under 18 years old.
In our experience at Children's Hospital, it's we're getting about 100 new patients with type 1 diabetes a year to our center, and about, let's say, 24, 25 of type 2s.
And that was unheard of, say, 20 years ago.
When I was in my fellowship, it was type 2 was so unusual. We'd get our colleagues in adult medicine to come down and there'd be a whole what they call grand rounds, and you wheel this unusual patient in. I mean, look at this rare disease. This only occurs in adults, and here's a kid with it. And unfortunately, it's become so common now that unfortunately so common that we have many kids that are afflicted with this disease.
Well, let's shoot here for the people that may be watching. Now, endocrinology. I mean, these fat around the liver becomes an endocrine gland, and that's pretty new too. The concept of looking at visceral fat being an endocrine gland. Tell us a little bit.
Well, it's unfortunately the fat causes endocrine dysfunction in a number of areas. The body fat not only disturbs your glucose metabolism, so you're more prone to diabetes, but there's what some people have called the deadly quartet, or metabolic. I think more people are calling it the metabolic syndrome, where abdominal or visceral body fat and increased body fat is associated with impaired glucose metabolism, cholesterol and lipid abnormalities, high blood pressure, cardiovascular disease, among other things, which lead to serious complications as the kids, I'm dealing with kids now, as the kids get older and older. And these have been shown to shorten life, and particularly together, if you have diabetes and high blood pressure and high cholesterol, and in addition, we're now seeing in kids the deposition of fat into the liver and causing what's called non-alcoholic fatty infiltration of the liver. And unfortunately, some patients end up with liver failure as well. And, so it's become a very, very serious problem. Many of our female patients end up with reproductive problems, with polycystic ovarian disease. Here, they're only in their teens. I mean, diseases.
All of this, pediatric endocrinology. This is crazy.
All used to be, like we said, were things that we used to call our adult colleagues. Look at this unusual disease. We thought was only in adults. Now we're seeing it quite commonly in our kids.
Well, even today, all right. Look at some advisory group or whatever I was reading today. New guidelines where the government had us all eating, the food guide pyramid, the breads and so forth.
Yeah.
It is still controversial, though, concerning red meat, from what I understand, the relationship with
red meat. It's red meat. Yeah.
The red. Yeah. I mean, I think soft drinks is pretty well. Everybody's kind of moving from toxic to bad, but nobody's putting it on a good shot anymore. Juices not toxic but bad. Nobody's soft drinks, juices.
Watching TV.
Yeah, watching TV. There you go.
We shouldn't be doing this.
Yeah, all of those things. But so we're all right on the carbs, the refined carbs.
Right.
All right, but whole grains are still protective on diabetes.
This is. I think there's a whole lot to be done with prevention, and if I would make a plea, as a pediatric endocrinologist, I end up seeing the kids maybe after they fall off the cliff.
Okay.
So by the time these kids often get to us, they're either severely obese, or they have diabetes, or they have diabetes and high blood pressure and high cholesterol and fatty infiltration of the liver and polycystic ovarian disease. None of these kids are born overweight or obese or with this type of diabetes. So something happens to them by the time they're born till the time, they're getting their teens. What is going on? How do we prevent it? It's a major public health problem, and it involves our schools, our way not only of how people eat and shop for food and cook the food from maybe the time the child is born and how much physical exercise they get. I mean, too often the kids, not only they're eating some of those undesirable food products, but they're also less likely to be going outside. They're always on some sort of screen, or it'd be their phone or their. How many times, right? You just have to walk in any place and there are kids texting and things like that, or watching TV or on a computer or something. We just don't get up and are active, and I think it's. You were talking about Hurricane Katrina before we started, but it's a perfect storm of problems which put more fat on kids and predispose them to diabetes and getting fatter and fatter and fatter. There's been some attempt to to try to break this cycle. Some of my colleagues at LSU are looking into this, and my colleagues at Pennington are trying to to provide tools and instruction and make differences in the school system to try to prevent this, because ideally we want to keep kids leaner so they don't get diabetes. I think once the kids are to such a weight that they get diabetes, it's very hard to get them to slim down. And I would say it's ironic that very often many of these kids end up on insulin, but insulin makes it a bit harder for you to keep your weight under control. So it's best to try to prevent the kids from getting diabetes and high blood pressure and cholesterol problems to begin with, rather than wait until they get diabetes. The sad part about this is that there are very few resources in the community to help kids. So if a kid's referred to us, kid has medical assistance. It's medical assistance doesn't pay for nutrition consultation, if you can believe it or not.
Well, let's throw this out. A couple of minutes left. Out of the whole foods of what a parent can do, because on parent, pediatric endocrinologists, you can't throw that on the kids. That's the parent. All right, for the most part. So the food group, do you, from your standpoint, looking at what's going on in the liver and the pancreas, say insulin, soft drinks still become a lot of people saying that's the big enchilada. If we just focus on that, not that we focus on that only, but as far as for contributing to this fatty liver and so forth. I
think soft drinks or other foods, the danger with those is that you can get in calories very quickly, more quickly than you can really burn them off. So, for example, if I have, let's say I have a soft drink, and I'm talking maybe a cup, 8 ounces, one of those little pony, baby cans of soda, and typically the amount of calories in that would be 100 calories. And I would drink that, and I say to myself, I just had 100 calories. Sorry?
Hey, great information, believe me. Hey, eat well. You got to work as hard as you can. Parents, somebody knock them in the head. Come on now. We got to eat right, do the right thing. Appreciate you.